Hello and welcome back to the second episode that we recorded at the UK Oncology Forum in Harrogate. I'm Steve Bland and I'm joined once again in this one by Wayne Douglas, who is the Programme Lead for Diagnosis and Treatment at the North East London Cancer Alliance. And Wayne and I were joined for this one by a couple of extra special guests who told us all about a really amazing piece of work that the Alliance is involved in. Enjoy. Okay, so Wayne, as you sort of teased, we are going to talk about Natera and the work that you guys are doing with Natera, and we're joined by Dr. Francesca Jackson-Spence. Hello, Francesca.
Hi, thank you for having me.
No problem. Thank you for joining us. And Dr. Angel Rodriguez. Hello, Angel. How are you?
Hi, I'm doing well. It's an honor and a pleasure to be here.
Well, it's good to have you along. I'll get you guys to explain your roles because, Francesca, your job title included a word that I wouldn't even know how to start to pronounce. So, but Wayne, first of all, just explain the work, very briefly, kind of the work that you're doing with these guys and why it was necessary.
Sure. So as part of the Cancer Alliance, one of the things that we are keen to do is support research and those innovative changes that will help improve the pathway for our patients. And I was fortunate enough to hear from Francesca and one of our leading urology clinicians in Bart to talk about kind of this project really, which is about really reducing the number of chemotherapy treatments patients are required to have, and that's really important because Francesca would talk about it in more detail from a patient perspective. But it's really important that we try to reduce those burden. It's a huge task, isn't it, for patients as they go along that journey to undertake some of that chemotherapy to reduce or to what's the word I'm looking for? Cure that cancer if we can. And so, that's where we've got to. And through Francesca, we've worked with Natera as well to kind of build this in North East London and test it from a NHS perspective for our public.
So, Angel, you're Senior Medical Director at Natera. Just explain who Natera is and what you're doing here.
Sure. So Natera is a blood test diagnostic company that essentially, today's theme is about innovation. Before we talk about innovation, we have to talk about what are the clinical challenges and scenarios that need to be fixed, right? And Wayne talked about essentially right-sizing the treatment for patients, right? Some patients, thank God we've had great innovations in the past that have improved patient outcomes. But the downside to that is that sometimes, patients end up being overtreated. And so the current challenge is how can we right-size the treatment for the right patient? Where can we safely reduce treatments in some patients? And where, the other side of the coin is, sometimes our treatments are not good enough. And where can we, improve upon or treat patients with more innovative therapies? So, with at Natera, what we do is it's a blood test that can allow us to potentially identify those patients that may need more and which ones could do well with less.
Francesca, let's go on then with your job title.
Yeah.
Just introduce yourself and what your kind of role in all this is.
So my name is Dr. Francesca Jackson-Spence. I'm a clinical research fellow in Genitourinary Oncology. So I treat kidney and bladder cancer. And I work at St Bartholomew's Hospital, which is in partnership with Queen Mary's University of London. And I'm currently doing a PhD. I work in lots of clinical trials in kidney and bladder cancer, and we are using these Signatera tests, that is the test by Natera, to try and personalise care for patients. So at the moment, if I give you a clinical example, a patient may have a cancer in their bladder and they have an operation to remove the bladder, which is a big surgery. But we aren't curing all the patients by doing that surgery. In about 30 to 50% of cases, the cancer actually comes back later down the line. And so we have developed drugs to give after the surgery to try and reduce that risk of the cancer coming back. They are not perfect. They come with side effects. They come with large costs to the hospital and big impact on patient quality of life. The burden of coming and having treatment when you've had a surgery to cure your cancer, but then you're sitting on a chemotherapy ward next to someone who may be very unwell, and you really feel like a cancer patient. And we are not very good at the moment at selecting which patients need that therapy and which patients don't. So if you think about, 50% of patients' cancer may come back, they might need that therapy. But we could also be treating some patients whose cancer may never have come back. And so they're exposed to this toxicity, these appointments, this large kind of hospital burden unnecessarily. And so the work we're doing, both in clinical trials and by this pilot, which we can talk about as well in a minute, is to try and better select patients for these therapies. And that will help patients, it will help reduce toxicity, improve their quality of life, but it will also help better use limited NHS resources. And we have some really exciting data coming from clinical trials. For any clinicians listening to this, the trials are IMvigor010 and IMvigor011 in bladder cancer that are probably going to change the scope of this. And what we can do is the way we can select the patients is we can use these Signatera tests. They basically detect fragments of cancer protein in the blood, and we can see whether the cancer is coming back based on whether we see these levels of cancer proteins, ctDNA we call it, being present or indeed rising. And it may be more sensitive than waiting for that cancer to appear on the scan. And so using these proteins in collaboration with Natera is a great way for us to help stratify which patients get therapy and which don't need it.
So how far into the trial are you?
So the IMvigor010 trial is completed and reported, and it was successful. It showed that using these blood tests to detect ctDNA predicted which patients would do better and which patients would benefit from adjuvant treatment after surgery. And that actually influenced and informed the design of a randomized phase 3 trial, IMvigor011, which has completed, but the results haven't read out yet. So stay tuned for those later in the year. So those trials are ongoing. And you can go to America, and most oncologists are using these tests to help with their decision making. If you go privately in the UK, Bupa and Aviva, I think, are two companies that will pay for these tests, but they're not yet available on the NHS because the kind of cost benefit is still being assessed, and we need a little bit more data to come out before it's going to be available to NHS patients. But I think if we look at the 5 to 10 year timeline, I think we really will be using these tests for patients as a standard of care, more than scans. And so we're doing this pilot to try and offer them to NHS patients now rather than waiting.
Angel, to me as a non-medical person, this all sounds unbelievably complicated and incredibly clever. How does it all work?
Yeah. So essentially imagine if we had a blood test that could tell us whether the disease is still there after surgery, or a blood test that could monitor the treatment response when you're giving it, or a blood test that could, better identify who is at risk of recurrence. Well, you might think that test already exists, but there have been significant sort of scientific challenges that have prevented us from having a test that is accurate enough to do those things. However, what's innovative about the Signatera test is that it's actually a personalized test for each individual patient, meaning we take a sample of the patient's tumor and also take a sample of the patient's blood so that we can then do something we call sequencing, right? We sequence the DNA of both the tumor and the patient, and we essentially identify sort of like a molecular fingerprint that is unique to each patient's tumor. By doing that, it allows us to be much more precise and accurate at, detecting, small levels of fragments of the tumor DNA in the blood, but also allows us to accurately measure the burden of the disease with a blood test. So this has essentially the potential to, replace scans in the future. It has the potential to, as Francesca mentioned, better identify patients who can get away with no treatment and still have fantastic outcomes. But again, more importantly, also it's about those patients who today's best curative intent treatment are not good enough to better route them into clinical trials for innovative therapies.
Mm.
When we've talked a lot on this podcast about the importance of collaboration between you guys at the Alliance and private companies or other alliances, as we were saying earlier, this is just another example, isn't it, of actually you guys going maybe outside of your natural world to look for solutions.
Yeah, absolutely. I've worked in the NHS for almost 18 years now, and one of the things that we've always done is just really look within our kind of own confines. And I think for me, the benefit of the Cancer Alliance and the way we have been able to work and operate is that we are able to kind of break down those kind of traditional barriers, I guess, really. And the exciting thing for me is, look, we might be at the forefront of something that's already, like you highlighted, Francesca, already available privately, but something that will really make a huge difference to some of our patients. And for me, that's my challenge. In North East London, I want our patients to be first, and I want them to get the changes in their treatment. I want them to be prioritised in the right way and stop those appointments that are not necessary. And I think those two elements is why I think this is a fantastic piece of work that we're embarking on.
The wheels don't always turn that quickly in this kind of world, do they? So how soon realistically could it be before we see this being readily available for anybody?
So we are conducting this pilot at our hospital for 40 patients on the NHS for both bladder and bladder and colorectal cancer, whereby NHS patients not involved in a clinical trial that have had surgery can access these blood tests and help guide their treatment. And I think the results of that, if they are positive, will really help speed things up in terms of proving to key stakeholders the benefit in this. I think the timeline is, ambitious. I would love to say 5 years we'll be using these, but I would put my money on within the next 10 years. I think this is really the direction we're going. And, we've talked a little bit about deciding which patients would benefit from therapy, but also it's about earlier detection of later stage disease. If you imagine if you have a surgery and on the scan it looks like all your cancer's gone, or to the eye of the surgeon it looks like they've cut it all out, why does the cancer still come back years down the line? And that's because there's these tiny cells that are so small we can't see. A millimetre on a CT scan, it actually represents thousands of cancer cells. And these tests are being developed so quickly that are very sensitive at picking up just even small numbers of cells. And so it would also help us get treatment to those patients earlier. And you could sort of show that the cancer's recurred earlier than it showed up on a scan. So if we can prove that this not only helps us select who needs therapy and who doesn't, but also prevent late stage 4 disease, we're going to be able to show key stakeholders how much of a benefit this is for their resources and money, but also for patients.
Because that's like the first question, in my experience of my wife, but also people that I've talked to. When you get, a clear scan, your first question is, will it come back? You guys can actually answer that question potentially.
In the case of, I treat kidney and bladder cancer, which are aggressive cancers, particularly bladder, I rarely say to patients, you're cured. I actually never use that word because I've seen it time and time again whereby patients go through these big operations, they have treatment, the scan looks clear, and 3, even 5 years down the line, something starts to grow again. Yeah. And I think we've been a little bit naive to thinking that a clear scan means cancer-free, and these tests will help us actually determine who is likely to be cancer-free.
But that's actually sometimes the language of patients, isn't it, rather than you guys, because to hear it all the time, I can remember, and actually language of the media and things like that, isn't it? But I can remember my friend Dame Deborah James got a clear scan, but she had stage 4 cancer, and she went on the radio and said she had a clear scan, and in the newspapers the next day, she's cancer-free. And it's actually a different thing. But I can remember being in hospital with my wife Rachel and asking about kind of the chances of her cancer recurring, and the consultant said, well, there are some cancers that we think there's no way we'll see that again, and then a year later it comes raging back, and then there are some cancers where we think we're definitely going to see that again soon, and in 20 years we haven't seen it. So it's so hard to predict. And
exactly.
Actually, are you guys, Angel, you're providing an answer to that question that literally every cancer patient asks.
Yeah, and I think what's very interesting about what you mentioned is, in general, when we think of other diseases like let's say diabetes and let's say high blood pressure, patients relate to seeing a number go down to normal, which makes them be more adherent to treatment recommendations. Say when my when my blood pressure is now normal, then I tend to be more adherent to that. And I think what's difficult in oncology, and we talk about probability of it coming back. Not all patients have a math major to understand what does risk reduction mean, what does my risk is. Now, patients do feel side effects and adverse effects of the curative intent medication. So, it's difficult for them to put on a balance, the decision to move on with treatment. However, when you have residual disease that can be visible on a blood test, when you can see levels go down, it enhances that compliance and adherence. And I think just addressing adherence, I think, can make a significant impact in improving patient outcomes.
But I also think on that, it's not just about adherence to treatment, it's also the confidence to reject treatment. Because I have some patients who have surgery for colorectal cancer or for bladder cancer, and then we offer them this adjuvant treatment, which is basically treatment after surgery to reduce the risk of it coming back. And because that therapy exists, a lot of patients find it very difficult to refuse, but not everyone needs it. And so I do have some patients that have developed lifelong toxicity, things like type 1 diabetes, meaning they have to then inject themselves with insulin every day for the rest of their lives, who actually regret having these therapies. And they felt like they had to take them because we've shown by the data these therapies reduce your risk of the cancer coming back. You'd be mad not to take it. But actually, if we can say, you know what, your blood test after your surgery shows there's no cancer protein in your blood, you could be a bit more confident to say, okay, I won't have that therapy. And if that protein appears through serial blood tests every few months, maybe then we start some treatment. And I think that's also important because we really have this attitude that because healthcare exists and because drugs exist, we should take them. And I don't think that's always true.
You talked, Francesca, about the kind of the results of the trial and also how long you expected it to take. What's the process and how good do the results have to be in order to make it something the NHS would pay for? Because I know this is not just in this example, but there's countless drugs that we see in the media aren't funded by the NHS. How good do the results have to be to kind of build that case?
Well, there's two types of results we're talking about here. I guess the main randomized phase 3 results of the big trials that are globally led, they have specific criteria of what counts as positive result. So if you can show that you reduce the risk of the cancer coming back by a certain amount, or that you improve survival by a certain amount, then that is positive, and that's kind of a globally accepted thing. In terms of our pilot that we're doing in these 40 patients, we've got some criteria of how we're going to evaluate success in this way. So, for example, if we have patients that we offer this to, uptake to the tests and patients' attitude to the tests will be important. Because if you think about it, if currently everyone who's having surgery for bowel cancer or bladder cancer is offered treatment, and then we introduce this new test at just our hospital and say, if this test is negative, you might not need therapy, there's going to have to be a certain element of trust and confidence by patients to say, okay, I'll reject the treatment. So adherence and kind of patients' enthusiasm for actually changing their clinical decision based on this test, that's a marker of success for us. If we can prevent patients having treatments they don't need, so if we can say a patient declines treatment because this test was negative and the cancer doesn't come back in our time frame, that's a success marker for us. And if we can give treatment to patients who need it after their surgery and delay or prevent that becoming a later stage cancer, then that would be success. And we hope that this pilot will have answers in the next 1 to 2 years.
Wayne, do you have to do any education work with patients to kind of encourage them to get involved in trials and pilots of different things?
So yeah, in North East London, we've done a bit of work in terms of understanding some of the side effects and trying to increase the access to clinical trials as well. So lots of patients are concerned about kind of going on to a trial, and the old adage, if it makes them feel like they're a bit of a guinea pig, but it's completely not the case, and it's more about actually identifying the drug that's going to get the greatest benefit, I would describe. And so for me, I think it's really important that we try to push that message across, and we're working as much as we can. And Francesca, I think you lead a patient group as well. And so, utilising those forums to understand how we best talk to our patients and inform them in the best way, because sometimes, there's lots of information we give them, and actually we need to change the ways in which we do that as well to benefit them.
Yeah.
What are the patients saying to you then in your patient group?
This is a key priority for our patients.
Yeah.
I mean, think about it. It's a minimally invasive blood test that they're having anyway as a follow-up for their cancer. And it tells them information that is perhaps more sensitive than a scan and earlier than a scan. So we have a patient and public involvement group at Bart's, which I lead, and patients are always asking about this. Whenever we present our projects on this, they're always really in agreement this is a key priority. And I think this is going to get more and more, media exposure, and it's very palatable for patients. Scans are not without risk. They come with radiation risk. And that period of up to 2 weeks waiting between the scan and getting your results is a horrible time for patients in terms of anxiety and that apprehension of what the scan's going to show. So patients seem to be really keen that providing a blood test with a quick answer and potentially a more sensitive answer is going down really well with them.
What's the downside, Angel? There seems like there's no downside. This is just all positive.
Yeah, I think yes. So the theoretical aspect of that we're talking about here, and the science of it, and the validations that the test does what it does is real. But the truth is that with all that, you have to prove indeed that patients have better outcomes when you prove the test, and that's what these studies here, and that's why. Really what we're talking about here is that this is a win-win-win situation, meaning, one of the challenges with innovations is that the pace at which technologies advance is way faster than our ability to prove that these technologies allow us to manage patients better. So, at Natera, we're committed to doing these studies to prove these results, but we need collaborators like Francesca and her colleagues at St. Bart, and the fact that we want this test to be accessible to all over, as proven by the fact we have studies here, we have studies all over Europe, we have breast cancer studies here in the UK as well, because we know that is what is going to allow us to prove this. The sooner the better.
You must get impatient with things because you're like, I've got this thing that really works and can really help, but it's going to take me 5 years to prove it or something.
It's a real challenge, particularly in the UK. Things are slow to develop, and we get these exciting ideas and we see the data and we know it's good and we know it's going to benefit patients, but actually translating into being on the front line and patient benefit can be frustratingly slow. Yeah,
and it started in North East London, but we want to kind of grow that. We recognise the trial that we're doing, or the pilot we're doing in with Bart and with Francesca is the start of it really, and we're going to have a more in-depth conversation soon as well, because I think once we start to see some of those kind of trials completion, we need to kind of, I say drum up, but really, like you said, the media attention is going to grow. We need to be talking to our counterparts across the country, and like we've done today and earlier today, is collaborate across and say, look, this is some great work that's happening, and how can we grow this for our patients across the country? I'm selfish enough to kind of think about North East London patients, but clearly it's much wider than that.
I'll add as well is that with this test, this blood test, Signatera, it's like a Swiss Army knife that has a lot of utilities, a lot of tools, and in medicine there's a lot of different clinical challenges that we have, and there are scenarios where the test is like fit for purpose in today's current challenges, which sometimes may be difficult to prove down the road. And so that's where we see some of the early adoption of the test, when not all tumors sort of read the book, and not every patient is within guidelines, right, where we should treat them, and then either the patient or the tumor, you fall outside the guidelines, and that's when a test like this could really inform decisions, both for doctor recommendations and patient decisions.
So you must have to adapt the technology as you go as well. Like during the trial, you have to adapt to kind of different results that come up, different things you weren't expecting.
Absolutely. As we test the test, in a clinic, we realize that there may be scenarios where a certain use case, maybe the test, the technology needs to be fine-tuned. For example, there are some cancers that are more difficult to detect even with this blood test. And so then enhancing its ability to detect it at very low levels is something that is constantly happening, and we're constantly innovating.
Can I add one thing about, because I'm sure people were going to be listening and thinking, so why is this not happening? Why can't I get access to this test? And I think we have lots of data that is really promising in these spaces that this test is of benefit. We still have a little bit more to gather. Like I mentioned, the big bladder trial that hopefully should come out at the end of the year. We still need to see if that's positive. And the other thing is that because these are such novel technologies, they're costly. And so that's a limitation in terms of how many patients we can offer it to and how long it will take to get on the NHS. And so there are two barriers that make this not perfect yet, but I think we're really on the way to this being a thing that in a few years' time, this is the norm.
We'll come back to it in a few years' time and we'll talk about it then. Just before we go, Francesca, you were saying that this is your neck of the woods, Harrogate. What does this kind of conference, as a kind of medical person, what does this kind of conference mean to you? What do you kind of get from it?
I think it's a great showcase of the work that actually comes out of the UK. When we talk about oncology, the leaders are often Europe and America, but actually we do some great work here and we are very collaborative. Walking just into this room, I bumped into lots of colleagues from other centres, and I think for me that's what this really represents, is networking and collaborating and showing what we can do here and what comes out of the UK.
Have you told these guys where to go in Harrogate?
You've got to go to Betty's Tea Room.
Nice.
There we go, Betty's Tea Room. Thank you so much for joining. That was so interesting, and
Thank
really
you for having
appreciate
us.
it.
Thank you.